And as I said, we'll have questions at the end. So I'm going to hand over now to Herman to start the first session. Herman.
Thank you, Ruth. Hello, everyone. It's a pleasure to be here sharing our progress on this research agenda. So I'm going to start with the first out of a series of papers examining hospital utilization and hospital cost concentration in England. And we introduced this paper by stating the fact that healthcare systems worldwide face the challenge that a small number of children account for a large share of healthcare use and expenditure. Particularly in England, many of these children who use healthcare most intensively are also receiving special education needs and disability support or have involvement with social care services. From figures from the last fiscal years, you can see that annual expenditure on health, social care, and SEND is reaching approximately 10 to 11 billion pounds each per year. So combining how expensive these services are with growing healthcare costs and shrinking early intervention budgets, the entire system faces increasing financial stress. This leads us.
Man, can I just, there's a question. I don't know if it's Emily. Is there a problem? Do you want to ask your question, please? No? No.
Okay.
Okay. Thanks. Carry on, please.
Okay, this leads us to our motivating question for this paper, and is, could greater integration across health, education, and social care services improve or lower the cost and use of hospital services? And to do this, we believe that the first step is to fully examine the concentration of hospital cost and hospital utilization. So in this paper, what we do is we examine the cumulative concentration of hospital days. Sorry. Yes. So what we do in this paper is that we examine the cumulative concentration of hospital days and admissions in England and how this is associated with indicators of chronic health condition, SEND, and social care. We used a longitudinal birth cohort analysis to follow individuals from birth to age 18 and a rich set of descriptive statistics, concentration curves, and transition matrices to fully characterize both the concentration and the evolution of the concentration across childhood. A quick review of our results is that by age 18, the top 25% of children accounted for 67% of all hospital days and 59% of all hospital admission. We also found that there is high persistency in hospital use across childhood, and we will describe these results in detail later. Regarding the international literature, we wanted to highlight two key features of the literature. The first is that most of the international evidence of healthcare concentration comes from the USA, Canada, and New Zealand, particularly the one describing hospital concentration for children comes from the US and Canada. And from the limited evidence that exists in the UK, most of this research use small clinical samples and mostly cross-sectional analysis to derive their results. So our contribution to the literature is that we provide a population-wide view of hospital use in England and the first nationally linked longitudinal data assessment to examine cumulative hospital use up to the age of 18 and how this high hospital use overlap with other service needs. Regarding our data and methods, our main data source is ECHILD, and we will focus on a population that is characterized by all birth episodes recorded in the hospital episode statistic data from which is the 2004 academic year birth cohort, who were at least once linked to one school census record. Our outcome measures are going to be the cumulative number of hospital days in NHS hospital in England, and also the cumulative number of hospital admissions. We highlighted in green hospital days because during this talk, we are going to focus only on hospital days. You can find further information and further analysis on the preprint version that is available online. And what we mean by cumulative number of hospital days, here we have a little example. On the left-hand side, you can find the non-cumulative type of analysis in which each age is treated separately. And on the right-hand side, you can find the cumulative analysis in which we add hospital days over time. So by age 1 in this example, a child would have 3 days in total, adding 2 from age 0 and 1 from age 1. And we do this to ensure that our analysis captures long-term hospital dependence rather than seasonal or annual fluctuation in hospital use. Regarding our additional need markers, we catalog the children into 3 categories of additional need, which are chronic health condition, in which we follow the hard elite classification, the special education need and disabilities, and we classified children as having SEND, if they have any record of SEND support or EHCP in the education data, have any referral to children's social care services, are classified as child in need or looked after. Importantly, we use ever recorded measures. So our groups are constant across all childhood. Here we are not taking into account the differential timing at which each individual is receiving the services, but treating these groups as constant over time. So getting into our results, I will present 5 key results from these papers. The first is our analytic sample that comprises 481,000 children. As you can see from the table, 23% of them have social care, 38% have SEND condition, and surprise, one of these 3 additional need markers. In this graph, you can see the percentage of all cumulative admissions accounted by the top 1%, 10%, and 25% of users. And you can see that the top 1% of users accounted for 20% of hospital days by age 18, and that the top 25% of users accounted for 67% of hospital days by age 18. Our third set of results comes from the analysis of transition matrices. Here we catalog individuals in 5 mutually exclusive categories from top 1 to bottom 50%, And we
can I
describe the
interrupt?
transition from,
Sorry, Haman, your
yes,
screen
sure.
isn't moving. So I don't know if you can, that's it. So we've just seen the fly-ins, but we haven't got on to the
Okay,
next slide now. That's it.
sorry for that.
That's it here. Yeah.
Okay, so I was describing the transition matrix. Here we catalog individuals in 5 mutually exclusive groups from the top 1% to bottom 50%. And here we're
I think we're losing you, Haman.
the matrix. I'm sorry, can you hear me?
Yeah, we were losing you a little bit, Haman. And the slides are sort of jumping backwards and forwards, but we're still on your transition table
Okay,
one with the top
so now we're
1%.
focusing on the top 10% of the distribution.
Mm-hmm.
And what we are seeing here is that more than half of the children in the top 10% of users at age 1 remain at the top 10% at age 18. So from the second row, you can see that 59% of children that were at age 1 in the top 10% ended up being in the top 10% by age 18. And this is what we call high persistence. And this high persistence also occurs at the bottom of the distribution. So if we focus on the bottom 50% of hospital days in our analytic sample, you can see that almost 80% of children that were at age 1 in the bottom 50% of users ended up being in the bottom 50% of users by age 18. Now, I will move to our concentration curves analysis, in which we found substantial inequality in hospital days distribution. So let me start by briefly explaining how to read this graph. On the x-axis, we rank children from the highest users of hospital days on the left to the lowest users on the right. And here the vertical dotted line marks the point where 25% of children have been included. So these are the top 25% of users. And on the y-axis, we plot the cumulative proportion of each of the variables that you are seeing on the graph. So for example, if we focus on the blue line, the dotted line intersects the blue line at 67%. The 45-degree line describes the perfect equality world. In a world in which all children use hospital services at the same rate. So for example, if children were evenly distributed across the distribution, the top 25% of users would use 25% of hospital days. But this is not the case because there is high concentration. So as you can see from the graph, 67% of hospital days are accounted for by the top 25% of users. Every curve that you see above the perfect equality line translates into concentration. So now I will briefly talk about our additional needs markers that are described by the green and the yellow line. And here you can see that the green line describes the groups that have been marked as having a chronic health condition plus having SEND and or social care. And 60% of this group are in the top 25% of users. Similarly, the group that of children with only chronic health condition, 50% of them are in the top 25% of users. On the contrary, in absence of a chronic health condition, which is the red group, this group are the ones who have either SEND and or social care. Only 15% of these children are in the top 25% of users. And this convexity of the line shows like underrepresentation of this particular need group among the high rank users of hospital days. Now our last set of results describe the evolution of hospital concentration from age 0 to age 18. Here we highlight this key result that we have been discussing, and is that 67% of cumulative hospital days is accounted for by the top 25% of users. And when we disaggregate this 67%, we found that 76% of that total correspond to children with a chronic health condition, another 12% to children with special education needs and disabilities and social care, and 12% to children with none of these additional markers. So here, a chronic health condition is a key driver of hospital concentration, and this hospital concentration become increasingly concentrated with age. Now I will present our concluding remarks and our next steps. We found that the top quarter of individuals accounted for 67% of cumulative hospital days and 59% of admissions. There is high persistency in cumulative hospital utilization. The top users at age 1 remain top users by age 18. The chronic health condition is a key driver of hospital utilization. Individuals with SEND and social care contributes less than their proportion of the population to hospital utilization. And the combination of chronic health condition, SEND, and social care showed the most significant concentration and increases with age. The next step that we have on this research agenda is answering, can earlier adoption of statutory services help to reduce hospital utilization?
Thank you. Have you finished, Herman?
Yes.
Thank you very much. Well, maybe we could are there any questions of clarification? Thank you very much. I can't see any questions in the chat. Not sure whether there's any people with hands up. No, so we'll move on then to Shing. I think you've got control of the slides, so would you like to take over for your talk, please?
Yes, hi everybody. Hi, my name's Shing Lau. I'm going to present paper 2, the second paper within this seminar, and it's still from the same body of work that Herman has presented. So what I'll present is the compounding effects of education, social care, support needs on hospital costs throughout childhood. Because it's a similar topic with Herman, I'm not going to talk about the background because I think Herman has mentioned that in his presentation. So I'm going to jump straight into the aims. So the aims of this work really is to describe the variation in hospital costs across different combinations of health and additional needs indicators. So What we know is we know what are the main effects between chronic health conditions on hospital costs. And what we want to do is extend that and find out what the main effects are for social care on hospital costs and children with special educational needs on hospital costs as well. But because we're using ECHILDs, we can actually take advantage of this linked data set. And for each child, we're able to actually look into the compounding effects as well. So we know some children actually have all three of these indicators. Some children have SEND and chronic health conditions. And we're able to look at what will be the association of children with two of these markers on costs, which previously hasn't been done in England. We actually have a different study design here. So what we do is we take a snapshot on the 1st of April 2022 to identify children aged between 5 and 18. And we use the school censuses to do this. So this is a state school population. So our sample of 5 to 18-year-olds is around 8.87 million children. From these children, we link forward into the 2022-23 fiscal year into hospital episode statistics, where we actually add costs to the hospital episode statistics, which I will present in the next few slides for you in terms of how we did it. Similarly to what Haman did, we then, for each of these children from this snapshot, is track back throughout their childhood. And from hospital episode statistics for chronic health conditions, we take their social care information, and then we also take their SEND as an ever had indicators of use. One important factor here, which is a kind of deviation from how Haman was identifying service use, is here we're using one financial cost year, the most recent financial cost year. The choice of this actually was due to availability of data, and actually more importantly, it's the quality of data. So the quality of data going historically to then actually cost up is not as reliable as the more recent versions of the data. However, one of the things which is therefore a limitation is that children that we can identify in the data set, age 0 and 4, get admitted. And this is because we're unable to link these children for their health and their social care activities together. We also omit nursery age children due to duplications as well. So that's why we start at the age of 5 as of that time point. Straight on to costing. The cost that we're talking about in this presentation is hospital services from hospital episode statistics. We don't cost at the moment mental health services for children and adolescents. The methodology which we follow is what NHS England uses for their resource allocation. And we'll do a short little work through in terms of how we apply this. But just a little bit of background, in HERS, in hospital episode statistics, all the activity is bundled into groups of care or bundles of care, and these are separated. So these activities are separated by healthcare resource groups. And at this healthcare resource group level, you're able to apply tariffs, which are prices that the hospital got reimbursed to provide certain activities. You're also at this level able to obtain reference costs, which are the costs for hospitals to provide these activities. And then finally, the first step is this a specialty level. If we can't apply any costs, we use specialty averages. And the reason why we want to apply all three is that if we apply the first step, not all activity will be costed. So we want to cost as much as we can with tariffs. And of the activity we can't cost, we use reference costs. And again, of the activity we can't cost, we finally use average costs. I have a message saying my internet's unstable. Is it okay?
Coming through for me, all right. Yeah.
Okay, thank you. So this is a worked example for a very simplified version of the admitted patient care data set. So this data set we've put now into spell level. We obtained information such as the HRG code, which is the activity, the bundle of activity which the hospital would get reimbursed for or has costs, we're able to get costs for. We need to extract how this individual has been admitted, either elective or under an emergency. We need information such as the length of stay, how long they stayed in hospital, as well as the specialty for this example. And hospital episode statistics will have a lot more variables, but they're just not relevant for this specific example. So using the HRG codes, what we're able to do is to link in the tariffs. And hopefully it could change so the animation will pop up on the screen, but it's not moving. Okay, here we go. Oh, it's all coming in at once. Okay, so now this is as if we try to link all the HRG codes in the data set with HRG tariffs, which are the prices, the amount of money that hospitals got reimbursed to provide that care. But however, we're only able to link the two spells, so 1 and 2. And the way we actually put the price in how much the hospital got reimbursed for the activity is we use something called the trim point. So we take into account how the person gets admitted, but also a trim point, as well as excess bed days in case stays are over the trim point. So for this example, if we look at spell 1 provided this activity, so they will get paid this base price of 8,800. However, because the length of stay is longer than the trim point, the hospital gets reimbursed £272 per diem, so per day above the trim point. So for this specific example, through the calculation, this spell would be costed £10,000. On this as well, if the length of stay is lower than the trim point, then the hospital will be reimbursed the base value. So for this example here, 8,842 is what we put down. Because not all activity is linked with a price, then we actually then use hospital reference costs, NHS reference costs. So in reference costs, we've now linked in a separate data set, and we can have a cost for an additional HRG code. One thing to note here, I've highlighted in red length of stay, because in reference costs, we're unable to do what we do in prices and through the NHS tariffs. There's no trim point, so we just add an average cost to it regardless of length of stays for that activity. So for this example then, spell 3 would be given £9,000. And finally, we have one remaining HRG which remains uncosted, so we use the specialty average. Now what we do here is, let's imagine that this example, it was only 4 instances, 4 spells under one specialty. So we take the cost of the spells that we do have, generate an average, and apply that average to the activity which currently does not have a cost. So overall, just to give you an idea of what the proportions of the costs are from which of these 3 methods, primarily from the tariffs, which we would expect because this was the first method and the bulk of the activity should be costed by tariffs, which is around 78%. Just under 5% is through reference costs and 18% through the specialty averages. Now presenting the average costs and the proportions of costs by hospital type. We find this slide actually really interesting. So I want to focus your attention firstly on this 42%. So the majority of hospital costs, not the majority, the largest proportion actually comes from activity from admitted patient care. And even though the number of children who have been admitted in this fiscal year is actually lower than the number of children that's used in emergency care or outpatients, just because the average cost of each admission, 2,500, is much higher than the average cost for other activities, it results in a higher proportion of costs. The really striking finding, though, is the one that I've just highlighted now. So around 9,000 children have use critical care at an average of £13,556 each. This 9,000, so our population is around 8.8 million. So just over 0.1% of the population actually account for 8% of that cost. And this is just from critical care, by the way. So these children here could have actually been using other services too, but just for this service, that's 8%. And the average cost for a child is £317. We're going to show you some results, and what we're going to show you is a table of proportions of the populations with health conditions, similar to what Herman did when he was showing the concentration curves. We would also show a series of costs in terms of proportional total costs and average costs for each of these needs indicators, as well as coefficient plots, which I'll walk you through a bit later on. We do show some results for 18-year-olds only just for brevity, because it would be too many things to show in the slides. So looking at the proportions, we just for 18-year-olds, we've split this up for mutually exclusive and not mutually exclusive groups. So mutually exclusive would be, if we look at the Venn diagram, it will be the areas, the separate areas that you can see that's not overlapping. So each of these non-overlapping areas. And not mutually exclusive would be the entire circles. So similar to what Herman was finding, especially for chronic health conditions, Herman was finding around about 27.4% of his population has chronic health conditions. We're getting slightly lower because we're not taking birth cohort of around about 26.6%. An interesting finding here is that it's actually under half of the males and female population has not used social care, SEND, or a chronic health condition. So actually the majority of the population within the snapshot that we got actually has used an additional support or have a chronic health condition. And on the other end of the scale, around 6% of boys and 5.5% of girls have all indicators. When we're looking at proportions of total costs which come by these indicator groups, so I'm just going to focus on the females and the 18-year-olds. So these two arrows here, these colored bars actually represent chronic health conditions. So 27% of the female population have a chronic health condition, and this is associated with around just over 70% of the hospital costs. Focusing in on just this segment here, which is the all category, that's 5.5% of the female population, but that accounts for 22% of overall costs. Looking at the predicted average cost, what we find is as children age, the average cost, or the predicted average cost, actually falls over time, with the highest average costs consistently being the children with all the needs indicators. Looking at the SEND and social care, this is one of the curves that Herman was presenting. We could see that actually when compared to costs, it's quite low, and especially for males, it actually converges. But this graph here kind of shows you why the limitation of removing the children aged 0 to 4 is actually quite a large limitation, because it's these children that have the highest costs. So this downward trend that we can see, it's a lot steeper, and it does continue as well. Okay, now finally looking at the coefficient plot. So I first want to describe to you what this coefficient plot is. So the coefficient plot that we're showing is actually another way of showing one of the points that are on the graph previously. So if we take for females, for example, this constant term here, this constant term would be something like the non-category, where this average cost should be similar to around this area here. If we want to get the cost for the all category for females, if you add up all the numbers associated to each of these coefficient points, the number you would get at the end would actually be this point right here on the graph. So what we're doing is breaking up the average cost and finding the components of the costs. How we're going to read it is, for each of these points, there's the 95% confidence interval, and if this confidence interval actually crosses this 0 line, that's an indication significant at the 95% level. What we find here, though, which is kind of unsurprising, really, is that the children's chronic health conditions are the largest drivers of the cost, which is why it results in the highest costs. the interesting finding that we're getting is that over time, there's actually a deviation between males and females. So if I would have presented this graph for 5-year-olds, chronic health conditions, the two-way effects of social care chronic health conditions, SEND chronic health conditions, the males and females actually don't have much difference. But over time, there's a deviation between the genders to the point where by the time the individuals are aged 18, for males, there's no two-way effect. So having both SEND or CSC doesn't add anything statistically to the average cost. So just to sum up the results from this work, at the age of 18, 6% of children with all three indicators accounted for 21% of total hospital costs. 26% of children with chronic health conditions account for 70% of hospital costs. Now, comparing with what Herman presented before, we do have a slight difference, which I'll say the numbers first and I'll explain a slight difference later. So the most costly 25% of children in this work with costs in 2022-23 account for 78% of all hospital costs. Just to remind you of the findings from Herman, the top 25% of service users in terms of admissions accounts for 59% of admissions and accounts for 67% of hospital days. So it's more concentrated when we're using more granular levels of utilization. However, how this deviates is Herman's is the lifetime utilization across everyone from 0 to 18, whereas this one's just a snapshot of 1 year. So it is a difference, and it is a fairly important difference, but it's still nice to find out that the concentration is still roughly ballpark and in a direction we'd expect. In terms of compounding effects, we find no compounding effects for males except in the all category, and the SEND and social care category is not statistically significant, which is very similar to the concentration curves that Herman presented. We find differences between males and females, and possibly this is due to chronic health conditions between the genders being different and when they come on in the stages of life. And the next steps of this work, we'd like to add in mental health care costs, special educational needs costs, costs for social care, and then extend the analysis to look at differences geographically, such as local authority level. And finally, I'd like to thank you for listening. And these are our email addresses. So for paper 1, Herman is here, and then paper 2, I'm Shing Lau. So thank you very much. Sorry, Ruth, you're muted.
Sorry, I'm muted. Sorry. Yeah. So thank you, Shing. That was really well explained. Really very, very clear talk of something quite complex. So we've got 15 minutes for questions. I have unshared my screen. Is that right? Is that okay?
Yeah, that's correct.
Good. Okay. And I'm now looking to see whether anyone's got their hand up, or whether there's anything in the chat. So no, just somebody who left who was very complimentary. So as there's not many people using, or no others, I think, using ECHILD for economic analyses, there is perhaps a lot to grasp here. Shall I start with a question for you, Shing? I mean, I think it's a question that the whole team of us is trying to understand, is what's going on with the social care group. So why are they having lower costs? I mean, and this is a sort of open question to others. Do you want to have a shot?
So what we're finding is it's not actually the group that's having the lower cost. So when we're breaking it down into each of the component groups, the estimates are actually slightly higher. So they're still positive. It's just not statistically significant. unless it's in that category where everyone is in that all category. And I think the main reason is just because we've only got hospital costs. And the main driver of these hospital costs are going to be individuals that have the chronic health conditions. So it's not really a surprise when we're finding chronic health conditions which are associated with higher hospital use in the future to be the main predictors of that costs like that. So I think it's just when we're breaking it down into each of those those little groups, only having, when I say only, so the individuals that have only used children's social care, but they don't have any chronic health conditions or SEND needs, this is going to be like a group of people where you might not expect them to be the ones that are using more healthcare. So it'll be more, so they may be using needs in one sector, but in terms of their health might not be that much different to the people that we've not identified needs with. However, we do know that within that group of individuals, some of them do have more needs, which is then being reflected with just like slightly higher costs. So I don't know if that makes sense.
Thank you. Thank you for that. Now, there's a related question from Jessica. Jessica, do you want to unmute and ask your question, or I can read it out for you? Feel free to unmute. Don't think we're getting Jessica. Okay, so it's why do you think the costs are higher for females compared to males? Do you or Aman join in if you have any suggestions? Shing.
It's linked. No, it's linked to service use. So I think initially we don't have 0 to 4. This is why the 0 to 4 is problematic. So actually, the 0 to 4 group, especially the 0 group for the boys, is actually more expensive than females. We know over time, especially teenage years, and especially going into the later teenage years, there's going to be increases of what we identify as those chronic health conditions for females, centered around like mental health, and which then leads to higher hospital utilization, and especially when compared to boys. So in the female group, you might see a start to having a larger and a quicker increase in chronic health conditions, which then is related to more hospital use later in life. But at the start of life, the boys were more expensive. It's just that when we're showing the curves, because we don't have that young group, don't have the information to see the combinations of needs indicators, we actually can't reflect that. So boys are kind of more expensive early in their life, and then of the area that we can look at, it switches. So
thank you. And I think if Ruth Blackburn might say that it's also mental health in girls who use health hospital services more during adolescence. Okay, so we've got a question. Thank you for that. We've got a question from Emily Blackshaw. Do you want to unmute, Emily? Or
yeah, hi, can you hear me?
Yeah, and can we see you? We're just testing because we're not sure how well this works. But
I don't have a.
Okay, we can't do that. Okay. Go on then.
Yeah, I was just wondering, I guess it more relates to Hanan's presentation. I think I understood it that the SEND and children's social care, like any involvement group, were using less than the general population estimated number of days in hospital. Like that was where the red line was under the kind of the expected line. I was just wondering, why you think that was.
Okay, thank you for your question. It actually depends who are you comparing that line with. So in that concentration curve, we had 3 mutually exclusive groups, one with SEND and health condition only, and one with chronic health condition plus the other 2. So as having a chronic health condition is a key driver of hospital utilization, that's capturing all of hospital admissions. That's why they're overrepresented among the high rank users of hospital admissions. And from that fact is where the convexity of the red line for the group of SEND with social care comes from.
Thank you. Thanks. And Emily, if I can just jump in there, I mean, I think there is a concern that, those of us who have worked with sort of child maltreatment and social care for data for a long time, sort of concerned that there might be underuse of or under recognition of health problems amidst all the other social welfare problems being prioritised more. But, that's just we haven't shown that, and that hasn't been evidenced in a strong way. So thank you, Hemant. So Ruth Blackburn, do you want to...
Can I add a potential clarification as well? So I think actually that that SEND and social care group, from what Hemant showed, it doesn't show that they've used less than someone who doesn't have those indicators. It's just because the services are being concentrated with the people with chronic health conditions. So that's why you're gonna have groups that fall either side of that line. But if we look at what happened with the costs, even though they're very similar, if I predict what would happen if Hemant includes a line for no users, it would actually be under the graph for the SEND and social care. But we've not done that. But yeah, thank you. So.
Thank you. Ruth, do you want to ask your question?
Hi, sorry, I'm not sure if you can see me or not. Thank you very much. Really interesting talks. My question was really whether you'd considered sort of deaths earlier in childhood and if these were factored in any way, or whether they might be one driver of reduced costs in some groups where actually the level of health morbidity was really high.
I'll start with this one. I'm very sorry, Ruth. I should have said we've removed all children's death. So, yes and no. I generated a snapshot of children on the 1st of April 2022. So any deaths that happened like before that date, I've admitted the children and therefore not taken any indicators. Deaths of children within my utilisation year, they would actually be included because they were alive there, and then they would have their associated indicators. But I should have made that clear in the presentation on mine. So yeah, sorry about that.
Hemant, do you want to say what you did?
Yes, and in the case of the panel for our analysis, we stopped following them after death. So they are included up until the age of the death record. But since we restricted the sample to have at least one record on the skull census, it only happens to 0.1% of our sample.
Thank you. Okay, so I don't think we've got any more questions coming from the participants here. Just as a sort of general question to you all, does anyone want to sort of tell us a bit about economics questions that they're planning to address? And this is an opportunity particularly to speak to Shing about how you might deal with the healthcare costing challenges. No? Well, Ruth, go on.
A cheeky question. I was just wondering if there was any chance of you putting together a how-to guide or some other kind of tutorial on getting started with the cost analyses within ECHILD.
Yeah, we will be making the costing coding available for people. So once we've done this and then I've added in all the other costs, we will be publishing that code so that other users can use it. So definitely, I think one of the things with the code as it is, one of the things with the codes is it can't be one of these things which is pick up and play because they call upon so many different tables. So in my example, when I just put, oh, we're just going to merge tariffs in, it actually comes from quite a lot of different tables within each of these. For each financial year, we'll have a new sets of tables and like different ways of how they costed them. So it can't be a pick up and play. but it will be available, and we'll make it clear what year it is, and then it'll be quite clear how what fields you need to change to then be able to apply them. But yeah, we will make that available for everyone to use it if they need to.
Right. We don't want to put people off using the costs. And there's also then the costs for social care and special educational needs, which are also challenging. Okay. Here we are. Your extensions to mental health. So this is, sorry, it's JM. I can't see the name there. Oh, Jessica again. Jessica, can you unmute yourself now? We get to hear you. I know there's a bit of a lag on it, isn't there? Okay, we can't hear you. She says, I would be interested in your extensions to mental health when you start that work. So it would be good to keep in touch. Thanks. What are the timings of the mental health work in your next steps? Oh,
So as soon as possible, as soon as possible. So where we are at that moment is this. So with the national cost collection, which is the reference cost, by the way, they do publish mental health costs for spells and care contacts, which we then link to the activity that we have in the mental health data set within ECHILD. One of the issues is this, the cost currency. So in this presentation, I mentioned a HRG, which is a bundle of activity. And you could imagine that within the mental health data set, it's exactly the same thing. Activity is bundled in different ways. Such as it could be children high secure unit with certain things there, facilities, I should say. That's how it's coded in the mental health data set as it stands. It's not provided like that though in the cost data. So at the moment, there's difficulties bridging the cost data with the data that's actually in ECHILD's. So I'm currently, I'm in contact with NHS England's pricing team to get some off-catalogue costs from them, so that then I'm able to apply those costs to the activity. One frustrating thing is the more recent publications of the national cost catalogues, they actually do publish costs within the activity codes, which do exist in the mental health data set as it stands now. So we can put costs, but not for the correct financial year, if that makes sense. So we're now waiting for the correct financial year data to be provided, so then I'm able to then apply that cost to that activity. So until I get that, it will be quite up in the air. So sorry, Jessica, I can't be more precise than that.
Yeah.
Thank you. I'm not sure if, can you hear me now?
Yes.
Yes, great.
Oh, lovely, got there in the end. I was just wondering if any of your work might cover mental health support teams in schools at all, or are they a bit too recent for the data that you've got at the moment?
I don't think it would be covering mental health supports in teams, actually. Yeah, we'll be so mental health will be focusing on the main activities in the mental health services.
Is it the MHSDS data set that you're using? Yeah, so they are in there, but they were only introduced in 2019, 2020. So there might be some in there.
Okay, so that'll be through the contacts then. So maybe I'll have to have a look. I'm sorry. Yeah.
Okay, no, that's great. Thank you.
Thanks, Jessica, for raising that. And it's such a good example of how useful it is to have this seminar and sort of put people together, so you can continue conversations offline. So it remains, we're out of time. I just want to say a big thank you to Herman and Shing. You've done fantastic talks, and it's clearly the start of something rather than final results. And there's lots more to do with the economic data curation. And hopefully there'll be more researchers like Jessica and others that will want to help you with that. So thank you very much. The next eChild seminar will be in a few months' time, date to be arranged. But, do get in touch if you have sort of themes or topics or want to be involved in a future eChild seminar. Milagros Ruiz, who is the eChild manager, get in touch with her. So thank you very much. That's been a great session, and enjoy the rest of your day. Goodbye.